from ICANN Professional Education, and we are recording today's presentation. So just a reminder, if you have people in your facility that aren't able to attend live, we do have that recording option available to them. So good morning, everyone, and welcome to our respiratory program. This is the second in our two-part series. We're glad to have you with us here today as we talk about respiratory assessment and ABGs, looking at analysis and skill review. And Kelly Winsington, Dr. Whittington, who presented our first program, is continuing the series today. She's got a very interactive program, some virtual case studies for us to look at. So just want to make a few short announcements so we can get right to the program. Just a reminder, we are offering 0.5 nurse contact hours for today's program. You do need to complete an evaluation. That evaluation is going to pop up at the end of today's program, so you can fill it out then, or Liz will be emailing that out to you as a follow-up along with the recorded link so that you can have that. You've got other people.
I have a babysitter that comes to my house in the summer, so I can just leave my kids there, and it's just like
that link with them. And just a reminder to keep muted here today. I don't have control of that. People to mute if you get unmuted, just so we don't have any background noise. A lot of times I can mute people on my end, but with this program I can't. So sorry about that, and sorry about the reminders to keep muted, but we want to keep that. So any questions that you have, please use the chat box. We're more than happy, and Dr. Whittington's more than happy to answer those questions for you. So back today with us, Dr. Kelly Whittington, who's Program Director for the BSN program at SIU Carbondale. Dr. Whittington, do we have you on? And I'll turn it over to you.
Thank you, Kathy. So you guys know I really like to do a lot of simulation for our teaching. So for today, our simulation is I'm your patient, and we're trying to work through my respiratory status. So I'm actually presenting from the hospital. I thought I'd be able to go home last night, but I wasn't able to go home last night. So excuse the setting, but you guys are right at home in this. So we won't worry if the IV starts beeping, we'll just take care of it. So what I wanted to start with is to pull up our, thank you, Kathy. I want to pull up our PowerPoint from last time. And I also have Dr. Fox. Dr. Fox is my colleague at work. In case I start slurring and I need some help, she's gonna be here with me to help me out. So let me get my, okay. When we ended last time, we were looking at respiratory assessment. We were really looking at that visual aspect of respiratory assessment, what we need to make sure we were looking at with our patients. And then we wanted to also take it that step further. What were we listening for with our patients? And then when I was reviewing some of our responses back in our evaluations, I had a few notes to make sure that I cover AirVo and vents and Bipap. So we'll be covering that too with some videos at the very end here. So as we walk through this, let's start out by looking at that. What is that respiratory assessment, and looking at our objectives for today. Again, going over the priority aspects of that respiratory assessment. I tell you, I'm not in here for a respiratory system problem, but I've been very pleased with all the nurses as they've assessed my respiratory assessment. And it's kind of amazing to me that even though I'm not in here for a respiratory problem, how I can see a decline in my respiratory status just because I'm sitting around so much. And that's not my typical thing. So it really does play in a role, or it emphasizes how much we should pull in that respiratory assessment with all of our other body systems, especially if that patient has a change in their if they become more sedentary during this time period. Then we're going to identify the components of ABG analysis. We're going to go through a quick 6-step process to do that, really focusing on the first 4 steps, and then identify that expectant treatment options based on that ABG analysis. Again, as nurses, our role isn't to define treatment based on those ABG analysis, but it's to understand what those ABGs are telling us, and then to be able to have an intelligent dialogue with that healthcare provider on what we're looking for with that patient. What are we expecting that patient to happen next? What treatment options are available for us? And then so we'll know how to assess that patient, and then how to do that ongoing assessment when they're going through that next phase of treatment. So when we look through that respiratory assessment, again, this is going back to last time when we were looking at I think we were looking at our mannequins last time in my lab. The first thing we were doing is looking at that patient appearance. So noted if my patient was having trouble breathing, and I always base that on their ability to converse and what their oxygenation status looks like, what's their color looking like. I noticed a few times yesterday when I got dizzy or whatever, my ability to converse was really limited. So if we think about some of our COPDers, at this time of year in Southern Illinois, it's asthma season because the allergies are so high. So not able to fully give me a good detailed history on their respiratory symptoms plays into that respiratory assessment with that ability to converse. And then what are their complaints? Going into being able to tease out what is respiratory on that. So a lot of times if we say, do you have any trouble breathing? And they say no, but then when we go through it a little bit, well, how are you participating in your ADLs? Are you able to get up and go to the restroom by yourself? And they'll say no, because they get short of breath. They can't do that. So we're able to tease those respiratory components out when we're listening to their complaints. And then obviously doing that good objective assessment when we're listening to the lung sounds. Again, don't get tied up on third intercostal space down bisecting the clavicle, but make sure that when we're doing it on the right side, we're going right over to the left side and we're working our way down in a systematic process, both anteriorly, posteriorly, and then don't forget those sides, especially because we can get some good lower lobe involvement when we auscultate on the side. So don't forget that. And then oxygen saturation too, that's always going to give us a good idea of how our patients are able to utilize that oxygen that they have available to them, and if they need some supplemental oxygen that we mentioned last time. So keeping those things in mind as we're moving forward. You know, when we look at our ABGs, we're obviously looking at respiratory acidosis and respiratory alkalosis, and then we can do the same thing with metabolic alkalosis and acidosis. We're going to focus on the respiratory piece of respiratory acidosis and respiratory alkalosis. So with this first one, when you think acidosis, think of this gentleman here on the left who's in hypoventilation. And you can look at this guy and tell why he's hypoventilating. His lungs simply aren't expanding. And it's easy to see how he's tucked his chin. He's kind of taking a nap. He's falling asleep. He's got the big beer belly. So that's pushing down on his ability to help expand those lungs. So that's a pretty obvious one when we see that, thinking about how his lungs simply aren't able to do a good expansion. So he is doing some hyperventilation. But what if it's a little bit more subtle than that? What if it's a patient that's come back from a simple lap appy and they're hypoventilating because they're not splinting well with their pain, so their lungs aren't getting that full expansion. So think about some of those nuances of when we can see those patients hypoventilating, whereas with this guy, it's pretty obvious to me that he's not perfusing well. If I asked any of you guys to listen to him posteriorly and then on the sides, I'm pretty sure we could all say he would have very shallow adventitious breath sounds low in the basis because he's simply not moving that oxygen where it needs to be. I could ask you some another question. You could tell me right off the top of your head. If we checked his capillary refill, we know that's going to be sluggish. If I looked at his nail beds, we know that's probably going to be a little bit cyanotic. Just by what I'm seeing right here, I can kind of go in with that mindset that this man is hypoventilating. So we're going to see some of those signs when we start to do our full assessment of him. Versus the female on the right, and this is kind of interesting to me too, because I think they were working me up as an anxiety case when I came in with my neuro problems. So when we see an individual hyperventilating, that rapid tachypnea, so they're breathing over the rate of 20, they're blowing off carbon dioxide. So when we see those individuals, we tend to think about respiratory alkalosis. So that hyperventilation, they're breathing rapidly. Even when they're breathing rapidly, kind of similar to the hypoventilation, they're not doing that good oxygen carbon dioxide exchange. So with either one of these, even though we're going to see a respiratory acidosis or alkalosis state, we're still going to see that problem being that they're not perfusing well. So they're not taking in the oxygen as they need it. And then when they get that oxygen down into the alveoli, they're not able to make that good exchange of oxygen for carbon dioxide. So both of these individuals, we're going to see problems prolonged with them because of what they're looking like. So keep these in mind. Thinking about my hypoventilation, usually my individuals that I just don't perceive them as doing full respirations where they're doing that good lower lobe involvement. And then my hyperventilation where we're doing the more shallow, rapid breaths and blowing off a lot of my carbon dioxide. So the nurse understands that any respiratory health problem that interferes with gas exchange or the getting rid of our exhalation of carbon dioxide increases our risk for respiratory acidosis. So again, think about problems with gas exchange and then getting rid of or blowing off that CO2. If you think about what we've come through with the last 2 years, automatically our brain goes to COVID and then COVID-like symptoms. And now we're going to start talking long haul COVID and how we see pneumonia related to long haul COVID, et cetera. All of that's going back to talking about that interference in gas exchange being that carbon dioxide and oxygen exchange. So I think we're going to see this even with our patients that had maybe a mild case of COVID. We're going to see this long term with these individuals because of that interference with their ability to make that gas exchange. So look at some of my risks here that we have for those patients with respiratory acidosis. Any of our patients with a hemo or pneumothorax, again, hypoventilation because they don't have the lung mass to be able to do that exchange. Atelectasis, think about those patients that had COVID, and one of the primary complaints other than gas exchange problems we heard from them was that fatigue factor. So when we have that fatigue factor, think about how that plays into their turn, cough, deep breathe, moving around the room, etc., which will exacerbate or make that atelectasis even more detrimental to those individuals or more prominent to those individuals. We know that that atelectasis taken a step further is going to lead them into that pneumonia. Once again, when we get to that pneumonia, think all the way down to the alveoli, they're not expanding, they're not doing that gas exchange like they need to. So then they become full with usually bacterial or viral infection, which sets us up for that pneumonia stage. Again, when we're going back to our respiratory assessment and we're looking at those individuals, we're going to see that increased rate of breathing. So tachypnea for them, because they're trying to pull another more oxygen, we're going to see a decreased oxygen saturation because they simply don't have that ability to flip that oxygen and carbon dioxide in the alveolar. And then we're going to see those decreasing pulse oxes. So decreasing pulse oxes with this pneumonia is going to kind of red flag me to think about some supplemental oxygen therapy with those individuals. Pulmonary edema, who do I automatically think about with pulmonary edema? My CHF patients. So my CHF patients, as they are on their medication regime, if they don't do so well with their medication regime, or maybe they're doing okay with their medication regime, but they don't do well with their diet regime, and you know what, I'm going to sodium on that one. So when they don't do well with that diet regime and it holds on more sodium, we know right where that sodium is going to go because of that poor functioning left ventricle. It's going to go right into those lungs. So when we get it right into those lungs, that's going to cause, thank you, I'm sorry, thank you. I told you guys at the beginning, that's right, when the doctor's gonna pop in, I have a 30-minute window, that's when my physician popped in. So with that CHF, where that sodium is gonna hold on to that fluid in the lungs, and that's gonna make it much more difficult for our individuals to get their breath and their oxygenation with that. 3 more things, we can see it with sedatives and anesthetics. I really wanna think about it with our sedatives or our anesthetics, because with our patients that have had procedures done, then we're going to see them carrying over some of that narcotic drowsiness. You know how it is when we're trying to get their vital signs every 15, every 30, every hour, that we really want to encourage that turn, cough, and deep breathe to help oxygenate those lungs and get those alveoli expanded again. And then our chronic asthma patients can have this as well, again, for the same reasons. When we have that constricted bronchial airways, not only do we have that constriction, but then being able to get it down to the alveolar, which leads to my COPD patients too. So all of these patients, their primary medical diagnosis is telling me that they're going to have that subsequent problem with that exchange and interference with that gas exchange. So anytime I have that interference with gas exchange, that's going to lead me right into thinking these are my patients that are setting themselves up for respiratory acidosis. So keep that one in mind as we look at them. This is a nice little grid. I can send this around to you. It's on the PowerPoints if you want to cut this one out, but it's a nice little short and fast, sweet thing to look at when I'm trying to figure out if my patients, what their pH is. Then when I look at their respiratory or metabolic acidosis or alkalosis, telling me if it's low, if it's high, if it's within normal limits. So I'm going to keep coming back to this one as we kind of go through some of these and look at them. So my first one here, let's look at this. So I'm going to keep my former screen in line and think about that. My first thing I'm looking at here is my pH. If you remember, my pH range is between 7.35 and 7.45. So with this individual, they've got a pH of 7.3. What does that automatically make you think? Alkalosis or acidosis? It's an acidosis, exactly. So that's the first thing that we want to look at. Then my second step that I want to look at is analyzing the Pa Co2. When I'm thinking about that Pa Co2, remember my normal limits on that is between 35 and 45. So 35 and 45. My example here is at 55. So my Pa Co2 above that means that it's acidotic respiratory. So we're looking at this patient with a simple respiratory. Get this, guys. All right. We're looking at a simple respiratory acidosis with this one. So that could have been any of those patients I just listed on that previous screen. They come to us with that respiratory acidosis, and this is what their ABGs are going to look at. We can go down and do a little bit more extensive examination of this. In fact, let's do that. So step 3 is looking at my bicarb. So my HCO3, by normal with my HCO3 is between 22 and 26. This bicarb right here is 25, so it's completely normal. That tells me it's not going to be a bicarb metabolic problem. So again, it's focusing on that respiratory problem. The fourth thing we're looking at here is matching my Pa Co2 and my bicarb. We got stuff going off in my room and everything, guys. So on my Pa Co2, this one right here is specifically, we're looking at 80 milliliters of mercury. So when we're looking at that one, we're identifying that that's a little low. We'd like that to be higher for that patient. So again, we're looking at respiratory acidosis. Could have been any of those first patients that I listed on our screen. Again, think that when I'm walking in this room, I'm looking at that patient. They're not doing that good lung expansion. They are hypoventilating. So I'm seeing some of those issues with them, some of those more common respiratory diagnosis. Let's try it one more time. Okay, so as I go to this one, I'm looking at a pH of 7.49. So go back to my list. If I wanted to analyze that one, 7.49 is outside of my range of 7.35 and 7.45. So that tells me it's alkalotic. It's to the high end. If I do my second step, which is that Pa Co2, usually it's between 35 and 45. This one happens to be 40. So it's right in the middle. So right off the top of my head, I know I'm alkalotic and I know it's not going to be respiratory because my Pa Co2 is not involved, which leads me right down to my bicarb. On this one, when I'm analyzing my bicarb, it's between 22 and 26. And on this particular one, it's at 29. So that tells me it's high. So it's above my range of alkalosis because I know my alkalosis for bicarb is above 26, below 22 is acidotic. So on this particular one, my patient is in metabolic alkalosis. So I don't worry about these guys as much as I do my respiratory ones because my respiratory ones need a little bit quicker turnaround time to do something and to fix them. I wanted to pull up a few things when we're thinking about our patients. So when I'm thinking about my patients in our respiratory acidosis, which again is what we more commonly see, those are the ones that have that really poor exchange of carbon dioxide and oxygen. Those are my first patients that I want to think about oxygenation therapy, which is going to be our videos that I'm going to leave us on. So respiratory acidosis, they're not oxygenating, they're not perfusing. We're going to do some respiratory treatments on them, and that's what we'll end with here in just a second in our videos. My next thing is respiratory alkalosis, and that's the ones that I think about when my patients are blowing off too much oxygen. My example of that would be if my patient is anxious or if they're having pain and they're not able to breathe correctly and they're blowing off a lot of carbon dioxide. So we would want to slow them down to get that respiration rate down. And then my two that are under metabolic. So my metabolic acidosis, I usually think about those when I have kidney problems, poisoning, or underlying treatments. And usually our treatment for our metabolic acidosis individuals is to treat that underlying reason. If the kidneys aren't working, then we need to treat the function, get the kidney function where it needs to be. So it'll bring back up that bicarb, or bring back that bicarb level where it needs to be. And finally, our metabolic alkalosis, we might see this one a little bit more commonly because of our use of NGs and vomiting in the hospital. So usually when I have my metabolic alkalosis, I will treat that by trying to get that patient's nausea, vomiting under control so that we can keep those secretions where they need to be. So paying attention to fluid and electrolytes would be important with my metabolic alkalosis. So let's flip here and go to a few videos. Got two that we're going to look at. The first one is going to be on
And I can pull it up for you too, Kelly.
might be nice. I can't seem to pull it up with my thing. I need the first one with the Airvo. Kathy,
Okay.
I'm sorry, I can't pull it up with my screen here.
No problem. Just stop sharing your screen there and I'll go to my share screen. And which one is it that you're looking for?
The ICANN and the Airvo.
Okay.
So I did these two videos with help from respiratory therapists in the Southern Illinois Healthcare Network. So we're going to do two videos. We're looking at this one. They're going to show me Airvo and Bipap. And their point being on this one that we use this with patients who are low, they have very low movement of oxygen and carbon dioxide. So low movement here. So go ahead, Kathy. Thank you. No volume on that, Kathy?
We can't hear it, yeah.
Okay. All right, give me just a second here. Forgot to optimize the video clip, so let's try it again.
Therapists in SIH facilities. SIH facilities has one of our Illinois critical access hospitals at St. Joe's Hospital in Murfreesboro, Illinois. I have with me today Amy and Alicia. Real quick, say hi and what your experience is, background.
Hi, I'm Alicia Burgess, and I am the supervisor here at Memorial Hospital of Carbondale, and I've worked here for 14 years.
Thank you.
I'm Amy Williams, manager of respiratory care here at Memorial, and I am about 15 years in, most of that here at this hospital.
Okay, so I wanted that introduction for two things. A, they have a ICANN hospital within their mix, so they're familiar with what the nurse's responsibility is with that stabilize and ship methodology thinking that we usually think of. And then with that 14, 15 years experience, that means they saw us through COVID, so that's going to come up again. The first thing we're looking at is the Airvo. This was one of the things that was requested to look at. So ladies, I have two questions for you. The first one is, who do we usually see Airvos used with, and then what type of patients, and then what do we have to know down and dirty? What's the nurse need to know first off with the Airvo just to stabilize that patient?
So Airvos are used mostly for oxygenation and work of breathing. You can use them on COVID patients, we use them a lot on, and then we use them on early COPD exacerbations, that where their blood gases are fine, but they need a little bit of help because they're breathing hard. They're more of an oxygenation device because you can run it up to 60 liters and 100%.
So what does that nurse need to know just to utilize one of these?
Okay, so your flow meter here is not actually your flow. It is your oxygen. Your flow is determined on the device. So if you turn it on, it'll tell you your flow and your oxygen, and you just dial this up until you get your desired amount of oxygen. And then your flow is connected by you just up it to where we can. It can run 60 to I think 5 liters.
So we're using, to judge whether or not we're going off, we're using pulse ox. So we're using oxygen saturations off of pulse ox. And then if I look at a few things, this handy dandy machine has a direction card right on it. So go back to your facility, look at what you have for your airvo, understand how to set it up, and then work with your respiratory therapist to know real quick, how do I get this set up? Where's all that equipment? And how do I get to the next piece? The next thing I'm gonna go to is, do we have a BiPAP?
We do.
We
Okay.
have one over here.
We're gonna go to BiPAP next. So same type of question, ladies. If I'm thinking about a BiPAP CPAP machine, who are my usual patients that we utilize this with?
So your CPAP, this machine can do CPAP or BiPAP. So your CPAP is usually used with oxygenation issues, and then your BiPAP is used for ventilation. So COPD patients that you want to try to turn around before you have to intubate are really good candidates for the BiPAP. Fluid overload is another really good one. We use BiPAP a lot for that. Just anybody that's really having a hard time breathing,
Okay,
struggling.
so if you heard her first two things, her diagnosis would have been COPD and CHF, probably because of that fluid
Yep.
overload on those. Again, go back to your facility, look at your equipment, know how to set this up. What does the nurse have to know when they're seeing all this? It's a little overwhelming. What do I have to be able to do just to keep it there until the respiratory therapist gets there?
Generic settings that are good to start with are 12 IPAP over 6. Your EPAP is always going to be lower than your IPAP. And you can turn up your FiO2 to 100% if you want to until respiratory gets there. You want to have a good seal on your mask, the best that you can anyway.
Anything under 20. Zero's not always ideal because it can
Yeah.
cause breakdown on the face.
A zero.
So you'll have a little bit of leak. Don't strive for a 0 leak or anything. But if this thing's alarming at you and you have air blowing out everywhere, just kind of keep adjusting your mask until you get it where you want it.
So show me where my 20 or lower should be. 20 or
right here,
lower in my
total
leak. Okay. And then my IPAP needs to be, could start at 12. EPAP would be 6, and
Yep.
that's perfect.
That's, yeah, until somebody can get there and adjust it. Yeah.
And then make sure that seal is good on their face. That's what they were showing them.
Okay, Kathy, if I can come back to me for a minute.
Okay, you're back.
Okay. You can see where I am in the hospital. So what I'd like to leave us with, ladies, I'd like to send out the next video. That sound quality wasn't as wonderful on that as I'd like it to be. So I'd like you to be able to hear that better. I will send out both of those videos. They're about 4 minutes and both of them are about 4 minutes long. I'd like you to take a look at those and look at that with your respiratory person at your facility, just so you can run through, like I said, with these guys, what's the down and dirty that I need to be able to run this consistently without you here or until my respiratory therapist gets there. So what are those things I need to know? Where are all the pieces kept? Where is everything, so that I can be useful on that? And then I'll send out some more information on the ABGs. Again, focus on what do I need to know as that registered nurse to be able to identify that respiratory acidosis, alkalosis? What am I anticipating treatment wise, so that I can be about a step ahead of the ball game and understand what next is going to happen with my patient? I do apologize for the lack of professionalism today. We had a lot of chaos going on, but I think this is our world that we live in. So thank you for allowing me to participate from my hospital bed, and I'll get that information out with you. And if you want to see anything specific for next time, we are doing a chest tube insertion next time. So we will be going through that, but let me know if you have some more specifics. Do understand that it's a 30-minute, so we can't get into a great involved piece, but I'll be glad to incorporate some of your specific requests in the next piece. So I'll get this to Kathy so she can get those out to everybody. And I look forward to seeing you one more time in June from my office.
Yes, absolutely. When Dr. Whittington emailed me this morning and said she was going to be presenting from a hospital bed, I said, no need to, we can reschedule. And she said, nope, the show goes on. And you didn't miss a beat. I really appreciate the great information you shared today. Great review, great discussion. I see there's some discussion in the chat about CAHs who actually have respiratory therapists on staff, and someone responded that they're short staffed and have 8 nights this month, that there's no respiratory therapies. So know you're dealing with a lot out there. And so I know this review has been very helpful to everybody. I can send out those videos too, Kelly. I've got everybody's name and I have the videos, so I can just go ahead and send those out. The evaluation will be emailed to you. It will not pop up at the end of today's webinar. So look for that evaluation, and then look for our next invitation link for June 28th when we talk about ventilator care and continue this discussion. So thank you so much, everyone, for being here. Any final words, Dr. Whittington?
I do want to say Trish left a remark that she's short staffed and they've been 8 months with no respiratory therapists in house. So from that point of view, Trish, if there's something you guys need specific that would make your 12-hour shift, if not go better, at least more comfortable to you, shoot me an email and let me know that so I can be sure to get that for you. Because I feel your pain. I've worked in a critical access hospital when we did the same thing for budgetary reasons. They thought it would be nice to not have respiratory therapy from 11 to 7. So the nurses did it. So I know what you're talking about. Let me know if there's something specific I can look at for you.
And
Thank you.
absolutely, any comments do you want to put on the evaluation as to what you're looking for in next month's program, please include that, or any follow-up information, and we can work to provide that for you. So thanks everybody for being on this morning. Dr. Whittington, feel better, and thank you so much for a fantastic presentation.
Thank you.
And we'll talk to everyone soon. Have a great day.